Hello, everyone. I'm going to share my screen so we can get started. Let's see. Okay, hopefully you're seeing my title slide. I want to thank you, Sean, for that lovely introduction. That was a really inspiring video. I could see why Runcie has to hold back the tears sometimes. It's really incredible what she's been able to do over decades of commitment to honor her mother's legacy. Today I'm here to join you. I'm thrilled to be here to join you to talk to you about advances that we've made in the last few years with regards to ovarian cancer screening, diagnosis, and detection. And since I'm the first speaker, I'm going to begin with some statistics that I think we're all too familiar with. If we look at the latest World Health Organization statistics that were published last year, the incidence of ovarian cancer is approaching 300,000 new cases worldwide every year. And unfortunately, a majority of our patients succumb to their disease within that time. This is in large part because most patients get diagnosed with advanced stage disease, as you can see in the graph here on the top right, where the 5-year survival rates are not very good and haven't really improved in a long time. Now, a big factor that contributes to that is the fact that we don't really have good screening tools for detecting ovarian cancer at its earliest stages, where we can have more opportunities for surgical cures. That has also limited our ability to understand the molecular sort of pathogenesis of these tumors until more recently. Complicating that further is the fact that ovarian cancer isn't a single disease. This illustration is highlighting the 4 main subtypes of ovarian cancer. And what you're seeing here on the left is what we call the serous carcinoma. I'm going to speak mostly about high-grade serous carcinomas in this talk, but there are other subtypes that not only look differently under the microscope, but they really exhibit a unique natural history, epidemiology, risk factors, how they respond to therapy, et cetera. And so, there's a heterogeneity in this disease that makes it even more challenging. So what I want to talk to you about today, this is our overview, is discuss the question, why is it so hard to detect ovarian cancer? I'm going to bring up 2 main issues that I want you to focus on. One is dynamic range, which I will explain, and the other is origins. And then what I want to do is take those insights that we've made in understanding those factors and apply it to how it's changing our approach to early detection and prevention, and to talk to you about some really exciting advances in just a handful of years since we came to appreciate where these cancers actually begin. So let's start with, why is it so hard to detect ovarian cancer? So CA125, which you're all familiar with, is a biomarker that was discovered in the early 1980s, 1983. It's used for monitoring patients who have cancer, but it hasn't been shown to be useful for screening in the general population. Now, that was the only marker we had until 2008. So 25 years later, another biomarker was approved by the FDA called HE4. And unfortunately, neither one of these is sensitive or specific enough for screening in the general population. So we don't really have a biomarker right now for that purpose. A very interesting and important study was published at the end of last year. This was the United Kingdom Collaborative Trial of Ovarian Cancer Screening. We call it the UK CTOC study. And this was a study of over 200,000 women, where they tried to ask, if we take the best that we have available now, which they called multimodal screening because they're combining 2 different approaches. One was a blood test for CA125, and the other one was a transvaginal ultrasound, and asked the question, if we use this for screening and following patients over long periods of time, can we have an impact on outcomes, on improving survival? And what they found was that this approach, compared to just either one of these approaches on their own, was better able to detect low volume disease, but unfortunately it didn't impact outcomes. And it really comes back to this question, why is it so hard to find a biomarker for ovarian cancer? And I think there's at least 2 big problems that I want to talk about today. The first problem is what we call dynamic range. And so what this chart is illustrating to us is the fact that in the blood, we know that the ideal biomarker is going to be in the blood because it's easy to access, it's not particularly invasive, the results come back quickly. The problem is that in the blood, it's full of proteins. Some of them are very common proteins, some of them are less abundant proteins, and potential biomarkers may be present among very common proteins that really make it difficult to find them. So what am I referring to here? If you look at the top left, these are the really abundant proteins in the blood, like albumin and others. And if you give you an example, there are 12 orders of magnitude between the least abundant proteins in the blood and the most abundant proteins in the blood. That is a lot. Here's an example of, here's PSA for prostate cancer. It's not a very abundant protein relative to the others, but we've been able to find ways to detect it early enough. The question is, if you're looking for a really kind of infrequent or hard to detect protein, like down here on the bottom right, how hard is it, more challenging is it when you have so many other proteins in the way to detect it? So I'm going to illustrate this to you in a couple of different ways about what 12 orders of magnitude actually means, right? So here is a fisherman who's trying to find fish for his little favorite fish down here in the bottom right. And if he's fishing in the Marianas Trench, for instance, the deepest part of the ocean, his bait is going to get eaten up by all the other fish that are at different levels in the ocean before it ever gets to his favorite fish down here, right? So this is the problem of 12 orders of magnitude when you're looking for something that's relatively rare down here. But I think the best analogy I have for this is my friend the ant. So let's put this into perspective. If we imagine that our friend the ant here is our biomarker, we can get down on our hands and knees and see it eye to eye and be certain of its identity. But let's see how the complexity of dynamic range in the blood would make this challenging. If we move away from the ant 5 to 6 orders of magnitude in distance, it would be like looking for the ant from the top of a skyscraper or a hill or a small mountain. If we move away from the ant 6 to 7 orders of magnitude, it would be looking like for the ant from a seriously big mountain at a distance. And if we move away 11 to 12 orders of magnitude from the ant, it would be like looking from the ant for the ant from the moon. That is how hard it is, 12 orders of magnitude, right, to really look for that biomarker that you'd be hoping to find. So how do we find the ant? The argument is that we've made is that you have to go to the source. And we would argue that you can't do that by looking for biomarkers in the periphery because you have this dynamic range problem. So to cut through all those proteins in the blood, you got to go to the source. Well, what's the source? Where the tumor starts. Well, that's simple enough. This is ovarian cancer. Let's look in the ovary. Not so fast. One of the things that we learned in the mid-2000s by studying the fallopian tubes and ovaries of women who had BRCA mutations, hereditary familial predisposition, is that many of these tumors actually start at the very tips of the fallopian tube, what we call the fimbria, not in the ovary itself. And we came to understand that there are different alterations within these cells in the fallopian tubes that are basically the precursors of high-grade serous ovarian carcinoma. Work from our group and others led us to identify some of these precursors in the fallopian tube. These are just histological images here on the left showing you normal fallopian tube. And more importantly, this tubal intraepithelial carcinoma, which is oftentimes abbreviated as STIC for the intraepithelial tumor. This is the precursor of high-grade serous cancer, can be found at the very tips of these fallopian tubes. And so that really did change the way we think about where these tumors come from and what we could possibly do to detect them earlier and perhaps intervene in forms of prevention. So how does the knowledge about dynamic range, which makes it hard to find things in the blood, and the origins, which we now know the origins are the fallopian tube, not the ovary, how do those two pieces of information help us with regards to early detection and prevention? And so I'm going to touch on 3 things today. One is going to be how this has really driven us to think about tissue proximal screening, and I'll explain what that is. And the other is going to be 2 approaches to prevention, one in the general population and one in the more high-risk population of patients. Okay, so let's start with the tissue proximal screening. We know, again, that the blood is generally the preferred source for monitoring a biomarker, right? It's non-invasive and it represents, we believe, the ultimate destination of where things from an organ or a diseased organ are going to end up in the blood. They get shed into the bloodstream. But again, discovery of new markers in the blood is hampered because of this dynamic range problem. There's just too many other proteins in there to make it easy to find the one potentially rare protein that is really telling you there's a problem. So in contrast, we argue that cancer-specific markers are going to be found at higher concentrations as you get closer and closer to the origin or the source of the disease, in this case, cancer. If we can get closer to the cancer, we should be able to find biomarkers that are enriched in there, haven't been diluted out in the blood by all those other proteins, and maybe we'd be able to identify markers that could tell us there's a problem in the fallopian tube. And this is what we typically call tissue proximal sampling or proximal liquid biopsy. So what does that look like? So here is an illustration of the female reproductive tract. So this is on cross section. So down here is the cervix. Here's the endocervical canal leading into the uterine cavity, and the fallopian tubes that take us all the way out to the tips of the fallopian tubes, the fimbria, and the ovary itself. Now, normally, the flow of the reproductive tract is what we call anterograde. Things flow from the fallopian tube down through the uterus, out through the endocervical canal, and out of the body. This is typically what we think about as the menstrual cycle, the menstrual period. The question we're asking is whether cervical pap smear, by taking a typical pap smear, or an endometrial collection of cells and fluids higher up in the reproductive tract, can tell us about what's happening even further up in the reproductive tract. Because if these early cancers are shedding cells or material from the cells into the uterine cavity and into the endocervical canal as they make their way out of the body, could we detect those by doing a procedure that we're all already familiar with, an outpatient procedure like a pap smear, and then look at that material for DNA alterations, protein biomarkers, or even RNA. And the ability to do this now has been made possible because of the amazing technological advances with next generation sequencing. And this is exactly what a number of groups have been exploring. For instance, and I'll give you an example of one study that we've been involved with where they've been looking at pap smear samples and able to detect alterations in the DNA from those samples that reflect some disease higher up in the reproductive tract. A group in Israel has done a similar study where they've been taking fluids from the uterine cavity here and able to show that they reflect changes in composition that are consistent with cancer in a cohort of patients that had cancer versus didn't have cancer. And another study was able to show that a similar approach can even detect RNA transcripts in the lavage of these cavities from women who either have a cancer or do not, and can reflect molecularly the presence of this disease. So it's pretty amazing what the technology is enabling us to do now, and there are a number of studies ongoing to look at this. This is one example of what these studies look like. So in this study, the investigators sampled three things. They did a pap smear using a typical pap smear brush. They did an endouterine sampling using a towel brush. So that goes further up into the uterine cavity. And then they also took a blood sample. And the question was whether we could look at all three samples and apply next generation sequencing. In this case, they called it RealSeq, to interrogate the DNA that's isolated from these samples for cancer-associated abnormalities. And these include copy number amplifications and deletions, which are very common in ovarian cancer. And so if you look at the top right here, one of the things they found is that in a healthy cohort of patients, so these are women without any evidence of disease at all, they were not able to detect any evidence of disease when they looked in this cohort of patients, neither in their pap smear, their towel brushes, or if they looked both at the plasma and the pap smear samples. However, when they looked at a cohort of patients who had endometrial cancer, this approach was really sensitive for detecting this disease, over 80%, approaching 95% if you included the towel brush sample. And that's not surprising because you're going right into the uterine cavity to collect the material. And so if there's a tumor there, you're likely to collect material directly from that tumor. And so this approach seems very good. But what about cancers that start in the fallopian tube? If we're sampling down here in the cervix or in the uterine cavity, are we able to really detect changes that are reflective of disease at the tips of the fallopian tubes? And so what the results here showed was that the pap smear alone has almost a 40% sensitivity of picking up cancers in the fallopian tube. The towel brush, which gets closer to the source, is a little bit better. But if you compare the plasma and the samples from the cervical canal, you see that you increase the detection rate even more. And this is particularly relevant because if we went back and looked at early stage cancers versus late stage cancers, we were able to see that even in the early stage cancers, we could pick up evidence of disease in these fallopian tubes. Obviously, the larger the tubes become, the later the stage, we're better at picking those up. But this suggests that this approach potentially is going to be a powerful way for us to use common outpatient procedures to detect cancers that might be higher up in the female reproductive tract. But it does beg the question, could we get even closer? And so to address that possibility, a number of investigators across the country, some of them through the NIH Early Detection Research Network, and some of us in collaboration with companies, especially bioengineers, have been looking at the possibility of developing essentially a falloposcope. I think many people are familiar with colonoscopies that we tend to have to get after the age of 50. The idea here is whether we can develop almost like a colonoscope, a falloposcope, to cannulate the fallopian tubes directly. This is as close to the source as you could possibly get, and actually sample the cells there to see if there's any abnormality in those fallopian tubes. And that's exactly what some investigators have done. So this is really reflecting the development of a novel hysteroscopic catheter, which is FDA approved, to collect samples from the fallopian tube to look at the cells and evaluate them. They didn't want to reinvent the wheel. They wanted to sort of use methodologies that already exist, just like the pap smear is already an outpatient procedure that people are used to. A diagnostic hysteroscope is also a well-established outpatient procedure. Typically, we use diagnostic hysteroscopies to evaluate the uterus for abnormal bleeding or causes of infertility or miscarriages, or even detect abnormal growths. And so what the investigators wanted to do is see if we could modify the hysteroscope to include another channel that would enable the investigators to deploy a balloon catheter into the fallopian tubes. And that catheter would go all the way out to the fallopian tube fimbrium and would be able to sample the cells in the fimbriated end and along the track of the fallopian tube. And when you retract the catheter, you would have essentially a pap smear of the fallopian tube. Here's just an example of some of the cells that come out of these falloposcope studies. And in one particular study that we were involved with, which was a multi-center study, women who were going to undergo a removal of their tubes and ovaries for pelvic mass or for prevention, let's say, because they had a BRCA mutation, were enrolled. And we had 40 women who, prior to their surgery, had their fallopian tubes cannulated and tissues cytology taken. And one of the things that was amazing was that when we compared the cytology results, really what the cells look like under the microscope, to what they found when they took out the fallopian tubes and ovaries after surgery, there was a greater than 95% concordance rate in terms of whether they found benign cells or malignant cells in these samples. And so this suggests that we might have a tool that gets as close as possible to the source, the tissue proximal source of biomarkers. And now there's a lot of work going on in our lab and in many others, trying to see whether we can look at these samples, these cytology samples from the tube, for evidence of genetic aberrations, again, using next generation sequencing, similar to what's been done with the uterine lavage or the pap smear that I described before. So those are examples that are getting us from the blood to the source of the tumor, right? If we get closer to the source, we can more readily and with more confidence detect these cancers and maybe identify novel markers that we can then go back in the blood to look for specifically instead of trying to do discovery in the blood. But the technology has gotten to a point where you can actually think about going back into the blood to discover, not necessarily proteins, but perhaps DNA that's shed by cancers. And so what do I mean by that? So here's an illustration of a study that was spearheaded by Victor Velkulescu at Johns Hopkins, and we've been working with their group to try to advance this even further. We know that as tumors grow, they grow, they die, they shed material. And a lot of that material can make it into the bloodstream. This material that we're interested in particular is what we call circulating tumor DNA. This is DNA directly from the tumor that gets shed into our bloodstream. And the question is, could we take a blood sample and look for those shed pieces of tumor DNA that is going to be very different than normal DNA? So here's just another example how the tumors can grow, and during the life cycle of each tumor cell, they can release tumor DNA into the bloodstream that then can be harvested. And using next generation sequencing, we can actually show that even though there's minute amounts of tumor DNA relative to all the normal DNA in the blood, we can identify sequence alterations, amplifications, deletions, all sorts of chromosomal aberrations and fragmentation patterns that are unique to the tumor. In fact, we've completed a study with Victor's group looking at the cohort of women who had late stage ovarian cancer, early stage ovarian cancer, women who are at risk but with no evidence of cancer in age-matched controls. And this approach, this liquid biopsy approach of looking for circulating tumor DNA was incredibly sensitive, more sensitive than what's available currently with CA-125. And so that's a very exciting opportunity, because it says to us that maybe the application of circulating tumor DNA may not only be in the role of screening and early detection, it may be useful for risk of recurrence, for guiding therapy and treatment and monitoring, and then really thinking about when tumors recur and become resistant, can we find them early enough so we can intervene in a more meaningful way? So those are a few examples, right? There's the tissue proximal fluid looking at pap smears and uterine lavages, the Falloposcope, which is a cool bioengineering development that enabled us to get as close to the source as possible, and then coming back to blood because the technology says that we can find some of this circulating tumor DNA. So 3 exciting developments in just a handful of years that says to us that maybe we might be getting closer to being able to do early detection in this population of patients. So that's early detection. What about prevention? Right now, let's go back to what we talked about before, the origins of this cancer, right? The origins of these cancers appears to be the fallopian tube. And the question that has come to mind for many clinicians and researchers is, if these tumors are really coming from the fallopian tube, is it possible that we could remove the fallopian tubes as a risk reducing measure without taking out the ovaries? Why would you want to do that? The reality is that when you take out the tubes and ovaries and we do the risk reduction surgery in that manner, we put women into surgical menopause at an age that they would not normally go through menopause. So at a much younger age. That surgical menopause is associated with all the comorbidities of normal menopause. So the cardiovascular disease, the bone disease, and all those factors that affect women as they typically gradually transition into menopause, typically a 5 to 7 year window. This is occurring almost instantly because you're removing the source of all the hormones at the time of surgery. A lot of women are hesitant to undergo that. They don't want all those comorbidities. And so there's been this discussion about whether we could think about removing just the tubes, since these cancers appear to be coming from the fallopian tube, and by doing so, provide them with equal risk reduction and avoiding the menopausal comorbidities. And so as early as 2011, a group in British Columbia decided to tackle this. So let me just sort of frame the story here. The work that led us to appreciate that the fallopian tube is the site of origin for these tumors really took place between the years 2000 and 2007. A number of studies from all over the world, Netherlands, the United States, a number of investigators were able to show that this, in fact, is where these tumors start from. A very thoughtful process for evaluating the fallopian tubes was developed, and all those results were then subsequently confirmed with additional studies over the years. So as early as 2011, the British Columbia group and the Society for GYN Oncology made the following recommendations. They said that due to its cancer prevention potential, it is recommended that physicians discuss the risks and benefits of bilateral salpingectomy, removal of the tubes, with patients undergoing hysterectomy or requesting permanent irreversible contraception. Given that the total benefits and risks of this practice change have not been defined, a national ovarian cancer prevention study focused on the fallopian tube removal is a priority for the Gynecologic Oncology Society of Canada. And really what they wanted to ask the question is what I just posed to you, right? Can we take the tubes from these women, not put them into menopause, and offer them equal risk reduction because we believe these tumors are coming from the fallopian tube? And that is exactly what they wanted to address. These 4 points here are also sort of potential caveats to consider. So one of the things they were aware of is that if you take out the fallopian tube, it shouldn't prevent cancers that come from endometriosis, for instance, which are not typically the serous cancers. These are the clear cell carcinomas or the endometrioid tumors. Or if in fact some tumors still come from the from the ovarian surface epithelium, removing the tube won't affect that either. And so removing the tube should not prevent ovarian-derived cancers if they exist. And so could we answer that question? And this is a study that was just published. I mean, literally not even a month ago. I think it's one of the most exciting studies we've seen in our field in a long time. So what do they do in this study? They address this question. This is a population-based retrospective cohort study of all the individuals in British Columbia who underwent opportunistic salpingectomy or a control surgery, which would be a hysterectomy alone or a tubal ligation, between the years of 2008 and 2017. They calculated the number of cancers they would have expected to find in both the opportunistic salpingectomy group and the control group. In this case, they had expected to find 5.27 cancers in the opportunistic salpingectomy group. What you're looking at here is a figure directly from the paper, which shows that they found no cancers in the opportunistic salpingectomy group, none. This was considerably less than the anticipated cases that they would have expected if there was some other source of this tumor beyond the fallopian tube. In the control group, they found 15 tumors. And very importantly, because they wanted to make sure that there was no selection bias, they were able to show that the expected and observed number of breast cancer cases or colorectal cancer cases in both groups, the opportunistic salpingectomy group and the control group, was equal. So these women had the same risk for getting other cancers as the opportunistic salpingectomy group, but removing the tube really prevented the development of these cancers in this cohort. So this result strongly suggests that opportunistic salpingectomy is an effective ovarian cancer primary prevention strategy at the population level, as there were no cases identified in the OS group. So that tells us about a population study that is giving us hope that perhaps removing the tubes instead of both the ovary and the tube might be a way for us to offer women better choices, better opportunities for risk reduction and prevention. But what about women who have familial predisposition, women who have mutations, let's say in the BRCA1 gene, which we know increases the risk of getting cancers? And so a study that we call SOROC, how you get SOROC from this, I'm going to let you try to figure out, but this is an NRG study. It's a non-randomized prospective clinical trial, that's the important part, that compares the non-inferiority of salpingectomy, just taking out the tubes, to salpingo-oophorectomy, which is taking out both the tubes and ovaries, to reduce the risk of ovarian cancer among BRCA carriers. Okay? This study was launched in 2020. I'm the site pathologist for the study, so I work closely with our team and all the various sites that are involved in this study. This has got an international component to it as well. And what we're basically trying to do in this study is compare how does bilateral tubal removal, salpingectomy, versus tube and ovary impact the ability to reduce emergence of cancer in this population of women. These women undergo surgical consultation, they consent to the study. We take transvaginal ultrasound imaging and a blood CA-125 every 6 months of study, within 6 months of study enrollment. And then the patients are put into either the salpingectomy group or the salpingo-oophorectomy group. Tissues are collected, they're evaluated by the site pathologist, and I do the central pathology review. And patient-reported outcomes are assessed every 6 to 12 months after the procedure. And the question again is, does removing the tubes in this cohort of women going to reduce their risk of cancer? Now, this is a long-term study. We're not going to know the results of this study for many years. But on the heels of what we learned about the opportunistic salpingectomy, we're very excited that this will also be an opportunity for us to offer these women who are at high risk of getting these cancers better options. So this study
Drapkin, I'm sorry to interrupt you. You're doing such an amazing job. We only have about a minute, so
yeah, this is the last slide.
So many people. Thank you so much. Appreciate it.
Sure.
Thank you.
So this study is going to look at this hypothesis. We're going to look at eligible patients are going to be these premenopausal women, ages 30 to 35, who have these BRCA germline mutations. There's going to be over 2,000 participants in this study, and we're going to be collecting all this data over the next few years. So what are the take-home messages? Hopefully, I've shown you that the most common ovarian cancers arise in the fallopian tube, and that this insight has really changed our approach to early detection and prevention. I've shared with you some really exciting technologies and advances, tissue proximal sampling, falloposcope, liquid biopsies that are showing really exciting promise for early detection. I think one of the most encouraging results is the results from the Opportunistic Salpingectomy study in British Columbia that showed that if you take out the fallopian tubes in this large cohort of women, you don't get serous carcinomas, and that hopefully this longer-term SOROC study will look at a similar approach, but in the BRCA mutation carriers. And so with that, I can tell you that I'm very excited where the field is going. I'm hoping that we're going to have better opportunities and options for women to participate in these studies and ultimately have better choices to make as we progress forward. And with that, I want to thank you for your attention, and I look forward to the rest of the symposium. Thank you.